I'll be moderating the next session. We have an announcement from the MUSC students. This should not take that long, so go ahead.
Hi, everyone. We're first-year perfusion students at MUSC. My name is Sophie Salentano, and this is Julia Fennell. We're doing a survey on international perfusionists, and if anyone knows or is an international perfusionist and is willing to share contact information, please come and find us. We have a QR code to share contact information, and we appreciate everyone willing to help us, and thank you very much.
Thank you. Thank you, guys. Thank you. Just a housekeeping item. We need 9 more donors for the blood drive. Walk-ins will be welcome in the South Down room located on the 4th floor. People can also sign up at the AMSEC registration desk. We have a goal to save 100 lives, and currently we are only 1/3 of the way. So please, if you can donate, we would really appreciate it. For our virtual audience, please submit your questions online. As I said, Greg and I, we are pleased to moderate this session, and we have an excellent speaker for us this morning. Dr. Ramee is a senior interventional cardiologist who specializes in heart valve and structural heart interventions at the LSU Medical School and LCMC hospitals in New Orleans. He has 3 decades of experience with his colleagues, nurses, cardiac surgeons, and perfusionists in this field. His topic will be transcatheter, aortic, mitral, and tricuspid valve updates. Dr. Ramee?
Thank you very much, Kareem. It's great meeting you, and thank you for inviting me to this meeting. I think Dean, one of our perfusionists at my prior employer, is the one who gave you my name. But anyway, it's a great pleasure to be here with you guys, because you guys are the reason that we're successful, and I mean that. What I'm going to talk about is transcatheter therapies, just to tell you kind of where they're going, where we are and where they're going, what they're used for. But I also want to talk about the role of mechanical circulatory support in the cath lab, basically, and where that is. And I know some people come from small programs, some people come from big programs. I think I had 8 perfusionists at my last hospital. I think I have 1 at one hospital now and 3 at the other. And we had 10 cardiac anesthesiologists at my last hospital. We have 0 at my 2 new hospitals. So there's going to be a spectrum, I know, and both of these are, not just community hospitals, they're medical centers. I have some conflicts that, as a doctor, we always have to say, but nothing that affects my speaking here. Who I am is demonstrated in this slide. I'm a veteran myself. That's how I paid for medical school. But this is my family. These top left is my grandfather, who immigrated and joined the military and went to the Philippines for 15 years in the Philippine Scouts, and was actually the top marksman in the military and the captain of the U.S. Army team. This is his passport picture, kind of a badass. The others are my aunts and uncles, most of whom went to West Point, except Aunt Ruth, who couldn't get into the academy because they didn't let girls in at the time, and my Uncle John, who went to Annapolis, was one of the first aircraft carrier pilots. This is my wife of almost 2 years now, and she's also been my boss for 20 years. Now, everybody starts out with a joke. I don't like jokes because I got in trouble. They're either racist or they're something. There's something-ist. So now I'm going to give you guys a way to save movies if you have a Macintosh on your computer, and this will help you, hopefully, in your life going forward. Okay, this is how to save a movie from your Macintosh, from whatever source. This happens to be EasyVisWeb. You can do an angiogram, an echo, any kind of movie. You can save it to your desktop for use in a presentation. you use the following keys. It's Command, Shift, and the number 5, all at the same time. Then you can adjust this box to include whatever you want on the screen. And then you hit record. And now it's recording. And when I want to stop recording, up here at the top is a little dot that appeared next to Zoom. And I'm going to hit that dot and it's going to stop recording. The movie is now on my desktop. I can grab this. It'll be listed on your desktop if you don't grab it. But I can grab this and put it in any presentation that I want. And it'll play. So this will hopefully make your lives easier. It's game-changing for those of you who give talks. What I plan to discuss today is transcatheter aortic, mitral, and tricuspid therapies, where we are and where we're going, and also the role of mechanical circulatory support in high-risk transcatheter patients, because I thought this would be of interest to you guys. My credentials, I'm one of very few physicians in the world that have been considered at one time or another an expert in every vascular bed. I'm sorry, the slides got a little jumbled when I sent them in, so I didn't have time to repair them. If they look funny or if they have spelling mistakes, I apologize. Anyway, I've been doing this since I was a fellow. I did my first coarctation balloon dilatation in 1983. Some of you weren't alive then. I've done various procedures since then, including percutaneous cardiopulmonary support, we called it, which is basically VA ECMO, starting in 1989. And that was before we had any kind of closure devices. And we did this without cut down. So you can imagine that was pretty hairy. Mitral clip and Watchman devices, TAVR. And then we started our heart team in 2009. And honestly, it's been a great experience, and my new employer wants me to do the same thing in my new position. So I'm working with a number of hospitals to try to do the same thing. Because of you guys, surgery has long been the gold standard for treating heart disease. You guys and cardiac anesthesiologists, you made it easy for them. And obviously I'm a big fan of surgery. But transcatheter treatment of heart valve disease and heart disease has been an increasing role because it's less invasive. And patients, nobody wants their chest cut open. Most surgeons don't even want their chest cut open. So everybody's looking for an easier option. Now, interestingly, I was working, in 2003, I was working with a company called Edwards. Most of you know them. And I was working with them to develop a femoral stent. There were no femoral stents that were approved, and at the time I was a vascular expert. I was invited by Edwards, who was a heart valve company, but was getting into the peripheral vascular arena with this new stent, to give a talk called The Future of Cardiovascular Surgery, an Interventional Cardiologist Perspective. Now, I was the only cardiologist at the surgery meeting, and you can imagine how well this was received. I basically said, anything you can do, we can do better. And this was in 2003. I already had a laundry list of what we could do and what we were going to be able to do in the future. And so one of my slides, I found this on my computer from 2003, was what can the surgeon do to ensure his place in treating cardiovascular disease in the future? And I said, you can innovate, retrain, realign, or retire. And basically, that's what happened. And I won't claim credit for it, but that's what happened. 20 years later, surgery remains the procedure of choice for most patients with failing native valves and three-vessel disease, complicated combined valve disease and coronary disease. But transcatheter procedures have replaced surgery for lots of high-risk and inoperable patients. Industry has borrowed heavily from surgical expertise and experience to develop minimally invasive transcatheter therapies, and the cardiologists and surgeons who were at war in 2003 learned to collaborate in order to do this. And actually, the next year in 2004, Edwards, not to my knowledge, because I had no idea they were going to do this, they sold the stent that I was working on for $200 million to Bard, and they turned around and bought THV, which is the transcatheter aortic valve, the next week. So a cash deal. So I guess I helped Edwards buy the transcatheter valve. I got nothing out of it, nothing. What the hell? So Anyway, the birth of the heart team at my former employer here in town, Oxford Medical Center, was in 2008. That's when we got together and we got cardiac surgery, cardiac anesthesiology, our perfusionists, interventional cardiologists, non-invasive and imaging cardiologists and heart failure cardiologists, EP guys, cardiac and surgical nurses, PAs and NPs, and recovery room, ICU, and floor nursing all together. And we basically put the patient in the center of that, and we developed a team that was extremely good, and I'm very proud of it. We started with transcatheter aortic valve replacement and moved on since then. Right now, there's 3 valves approved in the United States, the Sapien, the Medtronic, and the Abbott valve. And these have been established as a standard of care in moderate and high-risk patients with severe AS, and they're competitive with surgery in low-risk patients. But all the patients have an option, and it's a patient-centered procedure where the patient has equal input to the surgeon and the cardiologist. We can't treat ascending aortic aneurysms. Those are still all surgical. There's limited data for TAVR for AI. I've done TAVR for AI. I've seen the valves fall out. It's not something I like to do. The only people I've ever done it in are people with LVADs who have severe AI, and they're gonna basically have to have either a transplant or a new LVAD and surgery to close the aortic valve. So the 2 valves at the bottom right are made specifically for AI because they grab onto the valve and they don't need calcium. These are all in trials now. So the unanswered questions in addition to treatment for AI are treatment of asymptomatic AS and treatment of moderate AS, and those are both in clinical trials now. What about mitral valve disease? Mitral valve disease is really broad, and I don't consider myself an expert in mitral valve disease. I guess I am as expert as most cardiologists, but there are some that are more. But it's either mitral stenosis or mitral regurgitation, and it's either degenerative or functional. There's another category, which is mitral annular calcification, which is actually worse than mitral valve disease, and it's pretty much inoperable and untreatable at this point in time. The mitral valve therapies that are available are listed here: surgical valve repair and replacement. Most places don't have people who know how to repair valves, and so most patients in the United States and abroad get replacement. If I had a mitral valve that could be repaired, I would go to a place where they repair them a lot, because it's a lot better to keep your own valve. Transcatheter edge-to-edge repair, also known as TEER in the literature, that's why I put it on there, you'll see TEER. It's MitraClip and Pascal, 2 different companies. There's transcatheter annuloplasty devices that are in clinical trials, and there's transcatheter mitral valve replacement, also in clinical trials, but we can replace bioprosthetic valves in the mitral position now without occluding the anterior leaflet, without causing occlusion of the LV outflow tract by the anterior leaflet of the mitral valve. Mitral paravalvular leaks, usually done only in specialized centers, but that's also something we can do. These are the indications for therapy. Degenerative MR is surgical. TEER is only offered in high-risk or inoperable patients with liver disease, et cetera. Functional MR, there's no real role for surgery in that unless they're having another operation too, then they get a ring, annular ring. But we do transcatheter edge-to-edge repair in patients with severe functional MR due to either dilated atrium or dilated ventricle that's refractory to medical therapy. I'll show you the results in a minute. Rheumatic MS, mitral stenosis, balloon valvuloplasty is palliative and a bridge to mitral valve repair because it's not going to last forever. But it's good to do in these people. They present with PA pressures in the 90 to 120 range. Usually it's higher than the systemic pressure, and they're not good candidates immediately for surgery. Failing bioprosthetic mitral valves, we can do TMVR or reduced surgery. And patients with MAC, there's limited experience. I'm actually working with a company that's trying to decalcify these in vivo. We need newer treatments. So these are just pictures of the mitral valve therapies that are available, and on the right are a myriad of companies that are trying to make mitral valves that will solve the problems that we have now. The results with the MitraClip are good for functional MR. Again, this is dilated LVs, dilated LAs, but the long-term results are marginal because generally this is a muscle disease. You're not going to cure a muscle disease by clipping the valve. The mitral valve repair is good for failing mitral bioprosthesis, as I mentioned, but MAC remains a challenge for all of us. TR doesn't respond well to medical therapy. These people often get big livers, often get hepatic congestion, and often have cirrhosis and are inoperable. Tricuspid valve repair and replacement have a high published mortality, but some individuals are successful with this. Many TR patients are inoperable because of the comorbidities that I mentioned, and transcatheter tricuspid valve repair, or TEER, and replacement are in clinical trials. These are two examples. We have repair at the top, which is basically like a mitral clip or an annuloplasty, annular ring, and then replacement at the bottom, which are these basic valves. Some of them go in the tricuspid valve and some extend from the IVC to the SVC. The results with tricuspid results are really small numbers. It appears relatively safe, but there's no comparators. And the problem with case reports is if you kill somebody, you don't report it. So you only get case reports are only good for people who survive. So you have to take all case reports with a grain of salt. Ongoing clinical trials and medical therapy will hopefully be helpful. Clinical trials of replacement or repair versus medical therapy. Paravalvular leak closure. How many of you guys know about paravalvular leak closure? Okay, most places don't do this, but it's important that you guys know that they can refer this. They don't have to reoperate every time. That can be a mess. It's usually a suture that breaks, and it's because of inadequate tissue or inadequate, poor quality tissue, and it's usually between the aortic and mitral curtain. The causes are annular calcification, suturing technique, or infection, and the most common location I said is between the two valves. It happens in 5 to 17% of the patient. In the mitral, much more common in the aortic because it's harder to sew in the mitral position. Transcatheter aortic valve replacement also is subject to aortic insufficiency. In fact, early on, we weren't using CT scans to size the valve. So if you look at the partner 1 and partner 2 early data, the paravalvular leak rate was 80%. We were using parasternal long axis echo LV outflow tract measure to measure it. And those of you who've looked at echoes and TEs on these patients know that the valve is oval, and we're measuring the smallest diameter. So 100% of the valves were undersized. That's why all the patients had AI. Once we started using CT scan, less than 5% have significant or severe AI. This presents with really sick patients, hemolytic anemia, severe heart failure, or shock. And these are people that may or may not need some kind of support when we take care of them. And this is just an example. This is a mechanical valve that has a plug in it, and the plug is on the left-hand side of the screen, and it's on the right-hand side of the screen here. You can see it's a little circular device that we fit in there. Works very well. We usually use deep sedation and TEE to do them. This is an article I highly recommend you get because it really explains pretty much everything that I'm going to talk about for mechanical circulatory support in high-risk transcatheter patients and other cath lab patients. It's in Journal of Clinical Medicine 2023, and the first author is Grunenveld, Niels Grunenveld. I'll leave that up for a second. You can take a picture. It's about 15 pages long, but it's very, very good, and it's very well cited. So the types of circulatory support that we use include balloon pump, Impella, tandem, and VA ECMO. No surprise to you guys. High-risk patients include those with high-risk PCI anatomy, so left mains, people with bad ventricles, people who are already in shock. Some TAVR patients are high risk, mitral and tricuspid repair patients, and pulmonary embolism patients. All these people can be high risk. And so we work very carefully with our perfusionists to manage these people. The indications for mechanical circulatory support in high-risk PCI, which is coronary stenting, is either complex anatomy where you expect a long procedure, or left main, bifurcation left main disease where you're going to occlude flow to the majority of the blood flow of the heart and cause shock temporarily. People with low EFs and complex anatomy or low EF alone. Acute MIs who present with shock, and it can be right-sided or left-sided shock. Shock resulting from any of the above combinations. And we have Impella CP in the cath lab, balloon pump, and VA ECMO. I can tell you, I've only used one Impella CP in the cath lab, and that was a procedure that I was doing for the company to make a video of how to put an Impella CP in. I find it's not that much support, not that much more than a balloon pump for what I needed. VA ECMO, I rely heavily on, and I'm a very big fan of it. And I didn't put tandem heart there. Tandem heart should also be there. Indications for support are listed here. Hemodynamic instability, low EF, cardiogenic shock, severe AI, post-balloon valvuloplasty. Sometimes with TAVR, we get rapid pacing intolerance because we have to rapid pace to put the valve in, or arrhythmias, VTAC, VFib, or complete heart block with shock. And then cardiac rupture, annulus rupture, and tamponade. And I misspelled tamponade, sorry. But anyway, and yes, I've seen every one of these in my experience. Mechanical circulatory support in TAVR, in my opinion, is ECMO. I think VA ECMO is the best, the quickest, and the most definitive thing to use. There are no prospective randomized trials. It's used in about 4% of TAVR patients. So if you're doing standby for TAVR patients, understand you're only going to be using this rarely. And so we moved to an on-call situation where we have perfusionists in the hospital. We have a machine in the room, but it's not primed. And we're not basically spending the money and wasting the perfusionist's time by having them sit there the whole time. So we use it prophylactically in patients with hemodynamic instability. They present with heart failure or cardiogenic shock, which is not uncommon, or as rescue therapy if we have a procedural problem that leads to shock. The MUST registry is the only registry that I could find for mechanical circulatory support in TAVR. 13 high-volume TAVR centers over a 10-year period, and they only enrolled 87 patients. So that's less than one patient per site per year. Type of support was prophylactic in almost half, rescue therapy in half, and post-procedure in 10%. The ECMO was used the majority of the time, and for obvious reasons, I think that's the best. Tandem heart and Impella were used rarely. The MUST registry showed that prophylactic MCS was better than rescue. So it's better if you can predict a problem than cause a problem and have to use it as rescue therapy. We got to where we could put somebody on ECMO as rescue therapy in less than 10 minutes. But I think that's not going to be everybody's experience. 57% of the patients had complications. Only 10% were device related, but they were having complications because they were sick people, bleeding, vascular problems, stroke, et cetera. And there wasn't any difference in the complications between the type of MCS used. So my recommendation is to identify ahead of time which patients need ECMO, have the pump in the room, prime with a perfusionist, have ECMO available or on call for all TAVR patients, have the pump in the room but not primed, and identify who's going to do what. The surgeon, who's going to get access, who's going to hook up the pump, and have a perfusionist that knows how to work with you. In all cases, we have the ECMO cannula and clamps in the room, and I've done it always percutaneously. I've never done it with a cut down. It's easier and actually every patient leaves the room pretty much, even if we have a successful TAVR we remove the sheaths before they go in. We take them off ECMO. So it's just temporary procedural ECMO. We have a balloon pump in the room, but I don't know that we've ever used one. And I've been doing this for 15 years. What about mechanical circular support in the mitral position? In the mitral position, you got a lot of equipment in the right atrium and the left atrium and the IVC. So you're really not going to be using anything but balloon pump or ECMO. There's no prospective trials, usually used as a bailout. Impella is the most common one because it's all left-sided and cross the valve, but again, I haven't used that, so that's what the literature says. You have these big clip delivery systems in the RA, so you can't really have anything in the RA. Most patients survive, but again, this is self-reported data. Don't know how many didn't survive because they didn't report them. Pulmonary embolism is a growing thing. How many of y'all have been called for PE patients with shock? It's going to be more and more, so get used to this and read up about it, but it's generally, because it's a large clot occluding flow to the lungs, they're going to have RV failure, and that's what causes a shock. The blood's not getting to the LV. The LV is going to be small and woman, and the RV is going to be big and not moving. There's different ways that you can treat this. They may be in shock. They should be high risk for surgery or inoperable if we're going to treat them in the cath lab. We had a PERT team in my last place. We need to do that again. We need perfusion, cardiac surgery, interventional cardiology or radiology, whoever deals with the catheters thing on the call, along with the intensivist. Usually you can decide in a few minutes what you're going to do. These people are really sick. The types of treatment are intravenous lysis, which I've been doing, transcatheter lysis, or IV lysis is given a bolus of TPA, 100 milligrams of TPA. Then they get systemically lytic, and then you can't do anything else because they're going to bleed to death. IV lysis is, or catheter-directed lysis, with or without ultrasound, is where we put a small catheter in the PA, and I use a 4 French catheter, so it's minuscule, minimal risk. And then you just give a small infusion of TPA for 12 to 48 hours, depending on the patient, depending on the reaction. And I've been doing that for 20 years. Aspiration thrombectomy is a new thing, and that's what you're going to be seeing more and more of, because there's company after company that are developing these. There's no data or guidelines, and only case reports and small series to guide our therapy and our choices of therapy. MCS should be, MCS use included Impella RP and VA ECMO. So Impella RP to support the right ventricle if the patient's oxygenating well, and VA ECMO if they're not. So that's the end of my talk. I'll be happy to answer any questions, but I do want to end up by saying the heart team model, which includes perfusionists, cardiac surgeons, and cardiac anesthesiologists, and the rest of the team, including the nurses, everybody from the nurses to the patients, is well established, and it changed the way we take care of patients. TAVR is also well established in the treatment for most patients with AS or failing bioprosthetic valves, and that'll be the majority of your use in the cath lab, other than complex coronary intervention. MitraClip and Pascal have limited value for functional MR and TR, and probably if you're going to be using MitraClip or Pascal, you're going to be using Impellas most of the time. TMVR is used for failing bioprosthetic valves. Transcatheter paravalvular leak closure can avoid operations, and mechanical circulatory supports makes all of these possible in a high-risk cath lab patient. So thank you very much. I want to thank the organizers and thank the moderators for having me.
Thank you very much, Dr. Ramee. This is enlightening. This has been great information to have. Any questions in the audience? I'm going to ask the first question. When you implement ECMOs, did you have to take these patients to the OR for further, therapy?
No, we do it percutaneously. If we're going to leave it in, then we'll do an antegrade puncture as well, so we can perfuse the leg. But generally, in the cath lab for structural heart disease and mechanical circulatory support for the structural heart procedures that we do, we terminate it in the lab. The patients recover once their therapy is done.
Okay.
And I've never taken anybody to the OR for ECMO, but I know some places do that.
Okay. For our virtual audience, please submit your questions. Any questions here? Go ahead.
Bill Harris, New Orleans. Dr. Ramee, great seeing you again. You've had a spectacular career, and love to see you up here and continuing with that. I was able to work with you for decades, and just love having you in the new system. You made a quick statement that we would see more pulmonary embolus patients. Does that mean that we're going to intervene more, or is the incidence of pulmonary embolism actually increasing for whatever reasons?
So there's more catheter-directed therapies for them. There's about 20 companies developing ways to suck clots out of the lungs. And so they're going to take these very sick patients who are too sick for surgery to the cath lab and start sucking the clots out. I didn't list the companies, but there's a number of companies that are doing this. So I think they're going to be taking sicker people to the cath lab, and if they're smart enough, they'll include you in the algorithm because they may need your help. especially for the shock patients.
Will they include the thrombolytic therapy at the same time that they're trying to do these other therapies, or one or the other, or combo? Do you have any idea and insight into that?
Okay, so I think if the sicker the patient is, if they're healthy, they should go get on pump and get on bypass and have their chest open and have the clot removed if it's proximal. Normally, we have a CT scan, we have an echo, and we have the clinical appearance of the patient. Are they tachycardic, hypotensive, shock, et cetera? The ones that are too old or too sick for surgery will go to the cath lab and have catheter-directed therapy. And that'll include, basically either thrombolysis if they're not in shock, but if they're in shock, then they're probably going to get one of these aspiration techniques. And that's where mechanical circulatory support will come in handy.
Any other questions? Do you use the angiovac as part of your practice for?
Yeah, angiovac is one of the early ones. Yes, it's one of the things that's used. I'm not even going to remember the names of all of them. I'm bad with names. I had too much fun in college. But Imperative Care makes one. A company called Truvic makes one. Are
these handheld?
They're on the table. They're handheld, but actually, you may be involved in setting those up because some of them, they all use some type of suction. Some use aspiration by hand, some use wall suction. So I imagine that you guys will be involved in the acquisition and deployment of a lot of these devices. The handheld ones, they probably won't need your help for the aspiration, but they're going to need your help for the patients that are sick and in shock.
How many of you do angiovac procedures? Wow, that's pretty good. Question?
Yeah, hey, Dean Linder from Auctioner. Hey, Steve.
Hey,
Good to
Dean,
see you.
thanks for inviting me.
Yeah, of course. So I came in a little late. I apologize. I was at work this morning. I know, we had lots of discussion about the team when we were doing our TAVRs, and we kind of evolved to this in the hospital on-call thing. Do you see that similarly for the mitral procedures and the tricuspid procedures, or do you think I know you're a fan of VA ECMO, as am I, as being a perfusionist, but do you think it will evolve the same way where, as we get better at all these things, we're going to be on standby for those two, or do you see it more like in the room? I'm not familiar with the acuity of the mitral and tricuspid procedures.
So the mitral procedures generally are elective, and the tricuspid procedures are elective. They're scheduled weeks in advance, and the patients are tuned up before they come in. But you will see some of them that are too sick to go through the procedure. But again, those are probably going to be patients where you're going to use Impella support, and it'll be not, complete support just because of the accesses. I think I've used VA ECMO in one patient with a mitral clip, and we just used I'm not sure how we did it, to be honest with you. I don't remember how we did it. We did it one patient. Sir?
Hi, my name is Usama from Canada, and as we do more TAVIs and TMVRs, as we get better at them, and we offer them to healthier patients, do you think you'll see perfusion getting back in and more involved as we're offering them to patients who are full salvage? And do you see the patient population kind of changing in that matter, or do you think TAVIs are strictly for people where surgery is not an option?
Well, it's the results in the low-risk patients in the randomized trial, surgery versus TAVR, are pretty equal. And so I think the pacemaker rate's higher, but the other complication rates are higher with surgery. The pacemaker rate's higher with TAVR. And it's funny, he's from Canada, which is part of Europe, and he calls it TAVI. In Europe, they call it TAVI, if you're wondering. It was transcatheter valve, aortic valve implantation, but in the United States, we couldn't get reimbursed for a valve replacement because we were implanting. So that's why they changed it in the United States to TAVR, because of Medicare. Now, I don't know if I answered your question. Did I answer your question? Okay. Sure.
So by show of hands, who is currently doing TAVRs in their institution?
There's over 600 centers in the country now.
So how many of those are in the room on standby for every procedure? I guess about half of that. So I guess with the shortage of perfusionists, how did that conversation go from transitioning to an in-house, in-the-room model to an on-call model to kind of alleviate the perfusionist perfusionist from being in the room, because at least at our center, we haven't been in the room probably 5 years now.
Yeah.
And that transition was slow. We really just ran ACTs. It seems like that's kind of mostly what the perfusionist does. How did that conversation go? And if other institutions who are dealing with staffing issues, how do they begin that conversation with their leadership?
Great question. I would like to say it was to optimize patient care, but as everything else in the hospital, it was financial. One of our cath lab administrators, Vico, ran the numbers and found that there was a $3,000 charge on every TAVR patient, and it was for perfusion support. And so I got together with Dean, and we decided, they didn't really like sitting there. I guess they probably didn't mind getting the money, but they didn't like sitting there and not being used. So we came up with a plan where in our pre-op evaluation, in our morning of evaluation, we decided, does he need in-room standby, or can it be on call in case something goes wrong? And we decided, it was probably about 5 years ago also, that we would try doing it on call, and we tried it in selected patients first, and it worked, so that's pretty much how we do it. And I think we're pretty good at predicting who's going to need it and who's not. The hospitals I'm at now, one has one perfusionist and a bunch of contract perfusionists, and so they're not going to be in the hospital unless they're used. So it's going to be a little harder to change that there. So it really is going to depend on hospital to hospital, how many perfusionists you have, what they're doing. And I think it's a conversation that has to be done ahead of time. And I haven't had it yet. I just moved 2 weeks ago, so I'm going to have the conversation.
And I would just say to piggyback on that, since we had the conversation, we already have like rapid ECMO deployment in the hospital regardless, if we're in that room or not. So the ones that we weren't standby for, we just treated them like, well, what if this patient were in the unit and needed ECMO? We would do kind of the exact same thing. And so it did become very important for, I would get a text in the morning from Steve and be like, hey, we got one today that you got to be in the room for. And so, while it was financial, of course, we didn't do anything unsafe. We still were available. We still can have rapid ECMO deployment. So it really came down to communication, and that was kind of the key to it. And it was actually very, very successful for us.
And your cath labs can get their own ACT machines, so they don't need you for that.
I'm also going to add a comment to this. So we do standby ECMO in the room for every TAVR, and then we do pump in the room for every laser lead. But we just got asked by our cath lab if they could have one of our ECMO circuits and if we could leave it in there primed so they could go on ECMO if necessary, if a patient's crashing. And half of our team says no, half of our team says yes. I personally don't prefer leaving an ECMO circuit for cath lab to go on and then call us. If there's any issues, I would prefer them just call us. We're out of the hospital, it's a 30-minute call time, or we have N+1, so we always have someone available. What do you think about cath lab having their own circuit and going on? Not ECMO specialists, because I know, Dean, with teleperfusion, you guys have ECMO specialists go on. We have ECMO specialists, but they want to do it by themselves. What do you think about that?
Well, I think the ECMO specialists they kind of run the machines in the ICU after it's initiated and the perfusions have gotten things started. So they're basically perfusion extenders, if you will. Dean, you're gonna have to clarify this. I think we have our own machine. I don't know if perfusion owns it or not, but it's an extra machine that they don't need. And sometimes they may need to take it and use it on somebody else in the hospital, but we have enough machines. We have more machines than we have techs. And we have enough machines that we can leave one in the cath lab unprimed. We had it primed for the first 5 years, but for the last 8 years, I think we've had it unprimed in the lab. But if we need it, they can prime it and get it ready to go in 5 or 10 minutes, and that's what it takes us to get access. So I recommend in a hospital that's big enough that has enough perfusionists that you can spare an extra ECMO machine, that you leave one in the cath lab if they're doing high-risk procedures. I wouldn't want to put someone on ECMO by myself. I think I need a perfusionist to do that. Dean?
Yeah, and I would just say, yeah, so we have extra. So we always have the availability to leave one. But initiating ECMO without someone who's necessarily trained or licensed to do it is right. That's a gray area. I think it's important to understand if you're in a state with licensure, what does the license law say? So Louisiana's pretty clear, like anyone who's trained can monitor ECMO and monitor the patient, but interventions to the circuit and initiation of mechanical circulatory support that's extracorporeal has to be done by a licensed perfusionist. So that's kind of where it gets a little, we never had that conversation. I don't think anybody wants to do ECMO in our hospital besides the perfusionist, but yeah, so that's an interesting thing that's come up. Yeah.
I would discourage it just as a cardiologist. I think your knowledge and experience way exceeds ours in this regard. So it doesn't matter how big or small a hospital is. I wouldn't think it would be safe.
Hey, Dean, I have a question for you. How long do you keep a prime pump in the cath lab, either primed or dry?
Oh, wow, we're opening a big can of worms here, right? What does the literature say? So that's interesting. So we round on all of our equipment daily, and we have a 30-day expiration on any primed ECMO circuit as long as there's nothing visible in it. And we've gotten to the point now where we test after 2 weeks and test after 2 weeks to see if there's any growth. Yeah, like our infection control people kind of had a bug up their butts about that. And that's kind of why we instituted the checking. But yeah, I think it's institutional dependent, but we go 30 days on any ECMO circuit that's closed, as long as it's been primed according to like our guideline. Now bypass circuits go, 12 hours, but anything closed with no air exposure, we do 30 days.
Anybody
But it's
else?
rounded on daily, it's not like just sitting there. So someone goes up, turns it on, make sure that there's no air in it, that nothing's been bumped into it, there's no cracks, there's no leaks, turn on the heater, cooler, all that stuff, yeah.
Anybody else would like to comment on this?
Hi, Mindy Cooper. I just want to tell you, so they did try the cath lab staff putting patients on ECMO, and they quickly reverted back to having perfusion kind of take over. I know that it becomes a staffing and whether or not you have enough staff. I know in our institution, our ECMO patients, the numbers have skyrocketed, like I'm assuming most everybody else is seeing. So it became very apparent that we needed that N+1 model very quickly, and it was adopted very quickly.
Thank you, Mindy. There was several talks about AI yesterday. Are you familiar with any work going on with AI and transcatheters?
I assume you don't mean aortic insufficiency, you mean artificial intelligence? I think AI is everywhere. It scares me a little bit. I have a little bit of knowledge in that we were working to use EKGs to predict hypertrophic cardiomyopathy and aortic stenosis with a company when I left. So I think AI has a lot of value, but I don't know when or where they're going for low-hanging fruit now. They're using EKGs and echoes to try to diagnose things. I don't know that they're going to be looking at cardiogenic shock parameters and saying who needs ECMO and who doesn't in the next couple of years anyway, but it's really going fast.
Mm-hmm. Okay. Well, any other questions, guys? Well, Dr. Ramee, thank you very much for your presentation. This has been a great discussion. I want to make an announcement again. Where is it? So far, we need another 9 more donors for the blood drive. Walk-ins will be welcome in the South Dawn room, located on the 4th floor. People can also sign up at the AMSAC registration desk. We have a goal to save 100 lives. And currently, we are only 1/3 of the way. Also, everyone who gets a free AMSAC coffee from Shamrock Surgical. Thank you very much. Appreciate it. We'll see you at 11, I think, our next session. Thank you.